welcome to the deep dive. Today, we're tackling a really high-stakes area, vascular trauma in the head and neck.
Absolutely critical topic.
And our source material, it's top tier. Chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. So, we're getting into the expert-level details here.
Straight from the source, yes. And it highlights right away why these injuries are so, well, treacherous. It's that confined space.
Exactly. The anatomy is so layered and complex, just vital structures packed really tightly together.
Like a delicate piece of machinery, isn't it? One small bit of damage can cause huge problems downstream.
And the book makes a great point off of the neck injury isn't the most obvious thing at first.
Right. You might have major head trauma or chest injuries, even abdominal stuff that sort of masks what's going on in the neck.
Makes that initial evaluation incredibly difficult, a real diagnostic puzzle.
Yeah, those distracting injuries can definitely pull focus. You need a very systematic approach. Otherwise, you might miss subtle signs of a major vascular issue in the neck.
Okay, so that sets our mission for today. Cut through that complexity.
Yeah.
We want to understand the presentation, the evaluation, and the treatment for these challenging injuries.
Seems good.
Let's start with penetrating injuries to the carotid arteries. These are the big ones, supplying the brain.
Yeah, penetrating trauma, stabbings, gunshot wounds, they frequently hit blood vessels in the neck. It's unfortunately common.
And the stats are pretty sobering.
They really are. The source cites a stroke rate anywhere from 7% up to 27%, and mortality between 7% and 50%. That's huge.
Wow.
And get this, about 80% of those deaths are directly linked to stroke. It just underscores how critical time is. You have to manage these fast to prevent devastating brain injury.
Really stark numbers.
Yeah.
So the textbook introduces these 3 zones of the neck. Why is understanding these zones so fundamental?
The zones. Okay, so zone 1, 2, and 3, they're based on anatomical landmarks.
Right.
And their clinical significance. It's all about surgical access. Specifically, how easily can a surgeon get control of the vessel, proximal and distal to the injury?
Makes sense. Control is everything in vascular surgery.
Exactly. So zone I is low down, below the cricoid cartilage, think Adam's apple area. Getting proximal control there often means going into the chest.
Okay, more complex access.
Definitely. Zone 2 is the mid-neck, between the cricoid and the angle of the jaw. That's generally accessible within the neck itself. Both proximal and distal control are usually feasible there.
And that's the most common.
It is, yeah. About 47% of injuries fall into Zone 2. Zone 3 is high up, above the angle of the jaw, heading towards the skull base. Getting distal control there is notoriously difficult.
Tough spot.
Very. And of course, an injury track can easily cross multiple zones. So knowing the zone is critical for planning the surgery, anticipating challenges.
Okay, that clarifies the zones. Now, Rutherford's talks about hard signs and soft signs. What's the difference, and why is it so crucial to spot them early?
Right. This is a key concept. The hard signs are the really obvious red flags. They strongly suggest a major vascular injury that needs immediate attention, usually surgery.
Like alarm bells going off?
Precisely. Think shock. Blood pressure that won't stay up, obvious pulsatile bleeding, spurting blood, or hearing a bruit, that whooshing sound.
Yeah.
Also, a rapidly expanding hematoma, that collection of blood under the skin, or losing a pulse, especially if there are neurological changes happening too.
Got it. And the soft signs, more like warning flags.
Exactly. Soft signs raise suspicion, but don't automatically mean rush to the OR. They mean investigate further.
What are some examples?
Things like a history of major bleeding at the scene, even if it's stopped. A hematoma that's there but stable, not getting bigger fast. Nerve injuries nearby.
Okay.
Or just the injury path being close to major vessels. Even unequal blood pressures in the arms can be a soft sign.
And the correlation is strong for hard signs.
Very strong. The source says about 97% of patients with hard signs actually have a significant vascular injury requiring treatment.
Wow, okay.
Contrast that with soft signs. Only about 3% of those patients turn out to have an injury needing repair, but you still need to investigate them.
Really highlights the value of a good clinical exam right at the start. What about how the injury happened? Does that influence the suspicion?
Oh, absolutely. Mechanism matters. Gunshot wounds, for instance, are more likely to cause a big hematoma and injure a vessel compared to stab wounds. The numbers are around 27% versus 15%.
Significant difference.
Yeah. And then you have shotgun wounds, blast injuries, transcervical gunshots, the ones that cross the midline. Those raise the suspicion level even higher, much higher risk.
And it's not just the arteries and veins, right? Other things can get hit too.
That's right. Everything's packed in there, so you often see associated injuries to the airway, the trachea, or the esophagus, even the spinal cord.
Nerves too.
Definitely. Cranial nerves, the brachial plexus going to the arm. Other soft signs might point to these like painful swallowing or subcutaneous emphysema, that crackly feeling of air under the skin.
Lots to look for.
But importantly, the chapter emphasizes that a focused, good clinical exam is still very reliable. If the neck exam is normal, the chance of missing a significant vascular injury is actually quite low. Negative predictive value is 90 to 100%.
That's reassuring.
It is. Means we can be selective.
Now, there's a specific situation, mentioned patients who are comatose or have a major stroke or a known carotid clot. Treatment seems to have shifted over time for them.
Yes, that's a really complex group. Management has definitely evolved. Initially, the push was for revascularization, restoring blood flow.
Okay.
But then back in the 70s, there was a big fear of causing hemorrhagic conversion bleeding into the damaged brain tissue. So the pendulum swung towards ligating, tying off the internal carotid.
Just tying it off. Wow.
Yeah, but later studies suggested that actually neurological worsening was often due to the initial brain injury itself, or reperfusion injury, or swelling, not necessarily the ligation, so the thinking swung back.
Back towards fixing it.
Towards revascularization, yeah, that's generally the standard now, trying to restore flow if possible. Interestingly, there isn't a great preoperative predictor, apart from maybe a long delay, like over 24 hours, to say who won't benefit.
So early repair is often attempted.
Often, yes. And frequently it leads to neurological improvement or at least stabilization, even in these really severe cases. It's complex decision-making, for sure.
So how does all this guide the initial diagnostic and treatment pathway?
Well, patients with those clear, hard signs, they generally go straight to the operating room. No messing around.
Right.
But for stable patients without hard signs, the first step is often plain x-rays of the neck and chest. See the injury track? Look for air or blood in the chest.
And then not automatic surgery anymore.
No, there's been a definite shift towards selective exploration. The old way operating on every neck wound that penetrated the platysma muscle led to a lot of negative explorations, finding nothing significant.
So imaging became key for stable patients.
Absolutely. CT scanning, computed tomography, is now the main diagnostic tool for stable penetrating neck trauma.
Specifically the CTA.
Exactly. Computed tomographic angiography, using intravenous contrast dye and specialized software to get detailed 3D views of the blood vessels. It's incredibly powerful.
What can it show?
It lets you map the injury track precisely, see any vascular damage, its relation to the airway and esophagus. It can also pick up spine fractures, spinal cord issues, or if the injury extends into the head or chest.
It's accurate.
Very. For injuries needing treatment, Rutherford's quotes a sensitivity around 90% and specificity near 100%. That's why it's become the go-to for reliable diagnosis, especially in those harder to examine zones like I and III.
Impressive accuracy. Are there times when CTA isn't ideal?
Yeah, there can be limitations. Lots of artifact from missile fragments like shotgun pellets or even bone fragments can obscure the vessels.
So what then?
In those cases, you might still need traditional catheter-based arteriography, injecting dye directly into the arteries for X-ray imaging.
And ultrasound.
Ultrasound has a role, but it's pretty limited, mainly to zone 2. Things like subcutaneous air, fragments, hematomas, they all interfere with the image quality. Not really reliable enough for primary screening here.
Okay. What if the CTA finds more subtle things, like small tears or pseudoaneurysms, those bulges in the artery wall?
Right, those occult injuries, things like intimal flaps, dissections where the layers separate, or pseudoaneurysms, they're generally managed similarly to how we handle them in blunt trauma, which we'll get to.
Are they common in penetrating injury?
Isolated flaps and dissections are actually pretty rare with penetrating trauma. Pseudoaneurysms, though, are the most common occult finding.
How are they treated?
Depends on the size. Large ones often need intervention relatively early. Smaller ones, you might manage them non-operatively, maybe with antiplatelet or anticoagulant therapy, and definitely serial imaging to watch them closely. Make sure they're not growing or throwing clots.
The chapter also mentions endovascular options. Where do they fit in?
Endovascular techniques have become a really important tool. They offer minimally invasive ways to treat certain injuries, potentially avoiding big, complex open surgeries.
Like avoiding a sternotomy or tricky high neck dissections.
Exactly. Especially useful for Zone 1 and Zone 3 injuries, where surgical access is tough. Plus, many procedures can be done under local anesthetic, which lets you monitor the patient's neurostatus continuously.
What kind of injuries can be treated this way?
Things like pseudoaneurysms, some partial tears, or arteriovenous fistulas, those abnormal connections. Using covered stents to seal off the injury can be very effective.
But not typically for zone 2.
Generally, Zone 2 injuries are still managed with open surgery, mainly because access is usually pretty good there. But for Zones 1 and 3, endovascular is a major consideration.
Makes sense. So when open surgery is needed, what are the key considerations, the challenges?
Priority number 1 is vascular control, proximal and distal. And as we said, that really depends on the zone.
Preparation is key, I imagine.
Absolutely. You prep the patient, broadly legs accessible for a potential vein graft, chest prepped in case you need thoracic access for control.
How does the approach differ by zone?
For zone I with hard signs, you might start with a neck incision, but often you'll need to open the chest median sternotomy or an anterolateral thoracotomy to get that proximal control safely. You can't delay that if the patient's unstable.
Any temporizing measures?
Sometimes a balloon catheter threaded up from the femoral artery can provide temporary inflow occlusion in the OR. For zone 2, a standard neck incision along the sternocleidomastoid muscle usually works well.
And zone 3, the tricky one.
Still tricky. Initial neck incision lets you get proximal control and assess things, but reaching high up often requires more, maybe mandible subluxation, dividing the digastric muscle. If you can't clamp distally, you might carefully pass a Fogarty balloon catheter up the vessel to block back bleeding.
Creative solutions.
You have to be. Sometimes you can even do an angiogram through a tear using a catheter to visualize the injury relative to the skull base.
Once exposure and control are achieved, what are the repair options?
Okay, then you decide. Ligate, repair directly, or reconstruct. Ligation of the internal jugular vein or external carotid is usually well tolerated.
But not the internal carotid.
Ligating the internal carotid carries a very high stroke and mortality risk. It's really a last resort, typically only for unreconstructible injuries right at the skull base.
What about repairs?
Clean lacerations, like from a knife, might allow for primary repair just stitching it closed. But more destructive injuries, like from bullets, often need reconstruction. That usually means replacing a segment.
With what?
Often using the greater saphenous vein from the leg, sometimes an external carotid artery transposition, or even superficial femoral artery. PTFE grafts can be used too. Shunting is crucial, especially if the patient's in shock or hypoperfused, and generally recommended for all internal carotid repairs to protect the brain during clamping.
And heparin is used.
Yes. Systemic heparinization before clamping the artery is standard practice to prevent clot formation.
What if other structures are injured nearby, like the esophagus?
Yeah, combined injuries. That's critical. If you have an aerodigestive tract injury alongside a vascular injury, you absolutely must use the patient's own tissue, autogenous graft, for the vascular repair. No synthetics if there's potential contamination.
And separate the repairs.
Yes, very important. The esophageal or tracheal repair needs meticulous closure and drainage, kept separate from the vascular repair. You use a muscle flap like sternocleidomastoid or omohyoid interposed between them to act as a barrier. Prevents devastating fistulas.
And postoperatively, key concerns.
Close monitoring for neurological changes is paramount. Watch for cerebral edema, increased intracranial pressure. If you can't do a reliable neuro exam, consider direct ICP monitoring or serial CP scans. Early detection and management of complications are vital.
Okay, that's a really comprehensive overview of penetrating carotid trauma. Let's switch gears now to blunt cerebrovascular injuries, BCVI. Sounds like a totally different mechanism and challenge.
It really is. While BCVI is less common overall in blunt trauma, maybe less than 1% of admissions, the consequences when it does happen are severe.
High stroke and mortality rates.
Alarmingly high. Stroke rates reported from 25% up to nearly 60%, and mortality between 30% and 60%. Huge impact.
But recognition has improved.
Massively. Better imaging technology and just increased awareness have made a huge difference in detecting and treating these injuries over the last couple of decades.
What are the common ways these blunt injuries happen? 3
main mechanisms described. The most common, especially for carotid injuries, is extreme hyperextension and rotation of the neck.
Like in a car crash.
Exactly. High-speed MVCs are classic. The artery gets stretched over the bony prominences of the upper cervical spine, C1 to C3 usually. Interestingly, there are even reports linking BCVI to things like forceful chiropractic manipulation or even just jerky head movements.
Yeah. What are the other mechanisms?
A direct blow to the vessel is another. Think of a poorly positioned seatbelt across the neck, or sadly, in hanging injuries. That tends to affect the more proximal internal carotid.
Okay.
And the third is laceration by adjacent bone fractures. Basilar skull fractures involving the carotid canal, for example, can directly tear the artery.
Are there specific trauma situations where you should really suspect BCVI?
Definitely. Motor vehicle crashes are number one. Direct neck blows, pedestrians struck by vehicles, falls from a significant height, near hanging, these are all high-risk mechanisms.
And associated injuries.
Yeah, look for associated closed head injuries, facial fractures, cervical spine fractures, significant thoracic injuries. If those are present, your index of suspicion for BCVI should go way up.
How do these patients typically present? It sounds like it might be subtle sometimes.
That's a key point. Some patients do present with immediate signs of cerebral ischemia, weakness or numbness on one side, altered mental status, neurological deficits you can't explain just by the head injury.
But not always.
No, many patients are initially asymptomatic. The symptoms can develop later hours, days, even weeks after the injury. That latent period makes diagnosis really tricky.
Weeks later. Wow.
Yeah. There's also a specific type, a carotid cavernous fistula, that can present differently: eye pain, bulging eye, redness, maybe seizures. But often the symptoms depend on whether it's vessel occlusion or emboli, and coexisting brain injuries can mask everything.
So initial exam isn't always predictive.
No. The source makes it clear neither the initial Glasgow Coma Scale score nor the baseline neurological exam reliably predicts who will go on to develop BCVI symptoms later. That's why screening is so vital.
Right, the screening protocols. You mentioned those earlier. Is there a standard approach?
Not really a single universal one, but several well-known protocols exist. The Denver criteria were among the earliest, very comprehensive.
Yeah.
Then there are the Memphis criteria.
What kind of things trigger screening?
Things like significant neurological deficits not explained by imaging, low GCS scores like less than 6, certain patterns of facial or skull-base fractures, cervical spine fractures, near-hanging mechanisms.
Has screening changed over time?
Yes, there's been a trend towards trying to refine the criteria, make them more specific, trying to reduce unnecessary tests and costs. For example, just having a seatbelt sign on the neck isn't considered a strong predictor on its own anymore.
But the consensus is that screening is beneficial.
Yes, the bulk of evidence strongly supports having a formal screening protocol in place at major trauma centers. Finding these injuries before they cause a stroke is the goal.
So once screening is triggered, how do you actually look for the BCVI? What are the imaging options?
Well, it's evolved. Duplex ultrasound was looked at early on, but its sensitivity is pretty limited, maybe 40% to 85%. And critically, it often can't see the high internal carotid near the skull base, where many injuries occur. So, not recommended for screening.
What about angiography?
Digital subtraction angiography, DSA, was the historical gold standard. Great images led to the Biffle grading scale we use for severity.
But it's invasive.
Exactly. Invasive carries a small 1% stroke risk itself, resource intensive. So while it's still used, especially if other imaging is unclear or intervention is planned,
CTA has taken over.
largely, yes. Computed tomographic angiography, CTA, is considered the standard by many now. It's non-invasive, fast, gives great 3D views of the vessel wall.
And often done anyway for trauma.
Right. Many trauma patients get CTs of the head, neck, chest, abdomen, pelvis anyway. Adding the CTA sequences for the neck vessels doesn't add much time, contrast, or radiation burden.
How accurate is it?
Accuracy has improved dramatically with multi-detector scanners, especially 16 slice and above. Studies show sensitivity and specificity are now very high, some say comparable to DSA, particularly for carotid injuries.
And it makes a difference in outcomes.
It seems so. CTA-based screening programs have been linked to faster diagnosis and lower stroke rates. Getting that diagnosis quickly is key.
What about MRA, magnetic resonance angiography?
MRA gives beautiful images and assesses the brain too, which is appealing. But it's generally slower, less available acutely, harder for unstable monitored patients. And historically, its sensitivity for BCVI was lower than DSA, so less practical for initial screening in acute trauma.
Okay, so CTA is generally the workhorse now. Once you find a BCI, what's the typical medical management?
The mainstay is antithrombotic therapy, blood thinners. Though it's important to note this is largely based on observational studies, not large randomized controlled trials.
What do those studies show?
Early, really seminal work by Fabian, Biffle, and others showed that early treatment, often with heparin, was associated with significantly better neurological outcomes. Reduced deterioration, fewer new strokes, especially in patients found while still asymptomatic.
But heparin has risks.
Yes, anticoagulation carries bleeding risks, anywhere from 25% to over 50% in some series. Intracranial hemorrhage is the big worry, but other bleeding happens too.
So are there alternatives?
Yes, because of those risks, antiplatelet agents like aspirin or clopidogrel or both have emerged as a common alternative. Several studies suggest stroke rates might be similar between heparin and antiplatelet therapy.
So what's a typical protocol now?
A common approach, if there are no contraindications, might be starting with heparin, aiming for a specific level of anticoagulation, then transitioning to warfarin for maybe 3 months, or alternatively, using antiplatelet therapy, like aspirin potentially with clopidogrel, for that same 3-month duration.
And follow-up imaging is key.
Absolutely crucial. Repeat CTA or DSA is usually done around 7 to 10 days, and again at 3 months. You need to monitor the injury based on that BCVI grading scale, see if it's healing, stable, or progressing. Grade 1 injuries often heal, grade 3s often don't, grade 2s are variable.
When would endovascular treatment come into play for BCVI?
It's generally reserved for specific scenarios. Maybe a dissection that's clearly getting worse on imaging, especially if it's surgically inaccessible, or a pseudoaneurysm that persists or enlarges despite medical therapy, or if neurological symptoms worsen while on medication.
What can be done endovascularly?
Options include placing stents, either bare metal or covered stents. They can help tack down a dissection flap or exclude a pseudoaneurysm from circulation.
Follow-up still needed.
Definitely. Pseudoaneurysms often don't resolve medically, and dissections can progress. Even after stenting, you need follow-up. There are concerns with stents too: thrombosis, emboli, restenosis. Patients often need dual antiplatelet therapy long-term, maybe lifelong.
Is stenting always successful?
Experience has been mixed. Some reports show high occlusion rates with carotid stents for BCVI. Others report good patency. Treating dissected arteries, especially near the skull base, is challenging. We really need more prospective studies with long-term follow-up.
And when would open surgery be the choice for BCVI?
The indications often parallel those for endovascular therapy. The choice depends on many factors: associated injuries, injury location, patient compliance with meds, feasibility of long-term follow-up.
What surgical options exist?
For blunt carotid pseudoaneurysms, options include ligation, resection with reconstruction, or bypass. But again, surgery high up near the skull base is difficult and carries significant risks like stroke and cranial nerve injury.
What about lower injuries?
For more proximal, internal, or common carotid injuries, standard anterior neck exposure allows for a primary repair or maybe patch angioplasty using vein or prosthetic material. More straightforward access there.
Okay, let's move down the neck, figuratively, to the vertebral arteries. These sound like they have their own unique issues.
They certainly do. Vertebral artery injuries are less common than carotid, maybe 0.2% to 0.8% of trauma admissions. But control can be a major issue.
Why is that?
Because most of the artery runs within that bony canal in the cervical spine, the transverse foramina, that's V2, and then curves around C1 before entering the skull, V3 and V4. Getting surgical control there is much harder than the V1 segment before it enters the bone.
How do they get injured? Similar ways.
For penetrating injuries, yes, GSWs, stabs. Life-threatening hemorrhage from an isolated vertebral injury is rare, but they often occur with other major vessel injuries, which can be severe. Presentation can be asymptomatic or neurological symptoms from hematoma or direct injury.
And blunt vertebral injuries.
The most common mechanism is related to fractures of those transverse foramina, C2 to C6 usually. Because the V2 segment is fixed there, hyperextension or rotation can stretch or tear it.
Do they cause symptoms?
Often not, especially if unilateral. About 80% are asymptomatic because of good collateral circulation. A dissection might just cause subtle neck pain or posterior headache.
But they can cause symptoms.
Oh, yes. Vertebrovascular ischemia can cause dizziness, vertigo, nausea, visual changes, a whole range. Bilateral injuries are much more serious, potentially leading to coma, fixed pupils, respiratory arrest. And importantly, a significant number of patients with blunt vertebral injury also have a blunt carotid injury. Need to look for both.
How are they diagnosed? Different from carotids.
For penetrating, unstable patients with hard signs often get diagnosed in the OR. Stable patients need plain films and CTA of the neck, but you really want to include the head and chest too, trace the track, look for associated injuries, especially aerodigestive.
And blunt vertebral diagnosis.
Initially diagnosed with DSA, using the same Biffle grading scale as carotids. But here's a key difference. For vertebral injuries, the grade does not correlate well with stroke risk. The stroke risk is about 20% regardless of the grade.
Interesting. What about screening and imaging accuracy?
Still controversial who to screen, often using the same criteria as for carotids, but cervical spine fracture is really the only strong independent risk factor, and accuracy of imaging, generally lower for vertebrals compared to carotids across all modalities.
So CTA isn't as good.
Duplex is very limited. MRA has the usual trauma limitations. CTA sensitivity for vertebral injury is lower, maybe 40–60%, though specificity is better, 90–97%. Often, if you have high suspicion based on a C-spine fracture, you might need a confirmatory MRA or DSA.
How are they treated?
Medical treatment isn't really for penetrating injuries. For blunt injuries, symptomatic patients usually get heparin and close monitoring. Asymptomatic patients initially treated with heparin 2 based on data suggesting reduced posterior circulation stroke.
But now,
Given bleeding risks, aspirin is increasingly used as an alternative for asymptomatic patients. Current recommendations lean towards 3 to 6 months of anticoagulation for symptomatic patients with imaging follow-up. For asymptomatic, it's often either anticoagulation or dual antiplatelet therapy. For 3–6 months, evidence isn't definitive between those yet.
and endovascular options for vertebrals.
Yes, for specific situations.
Yeah.
Uncontrolled hemorrhage, problematic back bleeding from V3, pseudoaneurysms, or symptomatic patients who can't take anticoagulants.
What techniques?
Primarily embolization blocking the vessel, often with coils. Can be tricky, especially near the basilar artery. Stenting is rare, usually a salvage maneuver if other brain blood supply is compromised. But remember, many vertebral injuries thrombose spontaneously and need no intervention.
What about surgery?
For penetrating injuries with active bleeding found at exploration, ligation is often necessary but can be difficult, and unilateral ligation carries a small stroke risk. Post-op embolization is frequently needed to finish the job.
Is surgical access possible?
V1 segment access is feasible, similar to carotid exposure but needing careful dissection around the scalene muscles and phrenic nerve. V2 exposure within the bone, extremely difficult and risky due to venous bleeding. Proximal V1 ligation is usually safer. V3 exposure near the skull base. Most surgeons are unfamiliar. V1 ligation, packing, and embolization are generally preferred.
Okay, shifting again the subclavian artery. Thoracic outlet injuries sound immediately dangerous.
They are. Pre-hospital mortality is incredibly high, 50–80%. These are often devastating injuries.
Brunt versus penetrating.
Blunt subclavian injuries are rare, usually associated with major trauma like clavicle fractures, mediastinal injuries, pulmonary contusions. Penetrating injuries, GSWs, stabs are more common here.
How do they present?
Patients might be in cardiac arrest or have obvious hard signs needing immediate surgery. But remember, a normal radial pulse does not rule out a proximal vascular injury. Associated neck and chest injuries are very frequent.
What about arm ischemia?
Actually rare because of rich collateral circulation around the shoulder. Long-term problems are often due to associated brachial plexus nerve injuries, direct cuts, stretching, or even surgical injury.
Diagnosis and treatment pathway.
Unstable patient. Immediate exploration, often the only choice. Stable patient with soft signs. CTA is key chest, neck, upper extremity to define the injury location and assess the mediastinum.
What if the injury is minor on CTA?
Small intimal disruptions or non-flow limiting dissections might just be observed, maybe with anticoagulation or antiplatelets. Embolic symptoms, though, definitely warrant therapy and likely arteriography.
Endovascular role here.
Increasing significantly. Covered stent grafts are used more and more for pseudoaneurysms, lacerations, fistulas, even transections. It can potentially avoid very morbid open exposures. A large percentage of patients are candidates.
How's it done?
Access via femoral artery, brachial artery, or combined. You can even treat acute thrombosis with ischemia via retrograde brachial access and stenting. Most transected vessels can still be crossed with a wire.
Benefits.
Downsides. Big benefit is avoiding the morbidity of open exposure, especially nerve injury risk. Contraindications might be profound instability or maybe a huge hematoma compressing the brachial plexus, although sometimes stenting then evacuation is possible. Long-term patency in young, active patients is a concern due to thoracic outlet compression needs surveillance. But endo doesn't preclude later open repair if needed.
And open surgery.
Requires broad preparation, neck, chest, groin. Proximal control is the challenge. Median sternotomy for right subclavian innominate origin. High left thoracotomy, maybe with clavicle resection, for the left subclavian origin. Remote balloon occlusion can sometimes facilitate a more controlled approach, potentially avoiding the sternotomothoracotomy.
Can you ligate the subclavian?
In extremis, yes. Ligation rarely causes critical limb ischemia. Repair usually needs an interposition graft PTA. Often works well, vein if contaminated. Associated subclavian vein injury is common.
Finally, let's touch on cervical venous injuries. Similar principles.
Mostly penetrating injuries again. Blunt venous injuries are rare, usually with sternal or clavicle fractures. Internal jugular, IJ, and subclavian vein injuries are common companions to arterial trauma,
Diagnosis.
often found intraoperatively in unstable patients. Isolated venous injuries might show hard or soft signs, but rarely cause hypotension. Diagnosis follows the arterial pathways for each region. Delayed phase CTA can improve vein visualization.
Treatment. Endovascular.
Endovascular stents are used for chronic central venous thrombosis, but their role in acute trauma is less defined, mostly case reports, though with decent initial results. Maybe we'll see more use for isolated injuries in stable patients.
Surgical approach. Ligation. Okay.
Exposure mirrors arterial access. In extremis, ligation of neck and subclavian veins is generally well tolerated with limited morbidity. IJ ligation needs monitoring for cerebral edema, but it's rare. Subclavian vein ligation causes transient arm swelling managed with elevation compression.
Repair possible.
Simple lacerations can be repaired with lateral venorrhea, stitching the side. Extensive repairs are less common due to time constraints in trauma. Plus, all vein repairs have a high thrombosis risk, so thromboprophylaxis is important.
The chapter includes algorithms, flowcharts for management. Any key takeaways from those?
Yeah, they provide nice summaries. For BCVI, the algorithm stresses initial aspirin if safe, monitoring for emboli, escalating therapy if needed, and gives guidance based on injury grade for carotids and notes vertebral injuries need close watch.
And for penetrating neck trauma.
That algorithm focuses on stability, airway compromise, and the zone of injury. Hard signs like major hemorrhage, expanding hematoma, airway issues push towards immediate OR. For stable patients with concerning signs but no hard signs, CTA is central to deciding between observation, endo, or open exploration.
Lastly, the chapter highlights key references. Any that particularly stand out as foundational?
Oh, definitely. The work by Biffle and colleagues in '98 really raised awareness of occult blunt carotid injuries and the benefit of heparin. Cothran's 2004 paper further solidified anticoagulation as standard therapy.
Others.
Dimitriad's prospective study from '97 validated the physical exam for penetrating injuries needing repair. ESME's group showed in '06 that 16-slice CTA was equivalent to DSA for BCVI screening, and then in '09 showed CTA screening improved diagnosis time and reduced stroke rates. And Fabian's early work in '96 was critical in emphasizing early diagnosis and heparin for blunt carotid injuries. These papers really shaped modern practice.
This has certainly been a deep dive into a really critical complex area, head and neck vascular trauma, guided by the expertise in Rutherford's.
It really has.
It's clear, understanding those neck zones, the difference between hard and soft signs, and the evolving roles of imaging and endovascular treatments, it's all absolutely essential.
Couldn't agree more. And the need to tailor the treatment vessel, mechanism, patient status that comes through loud and clear.
It really does. And it's just remarkable how quickly the technology keeps advancing, constantly shaping how we approach these really high-stakes injuries.
Absolutely. It really highlights why ongoing research, refining protocols, adapting to new techniques, it's also vital for improving patient outcomes in this field.
Well, thank you for joining us for this deep dive. We hope this gave you some valuable insights into this challenging topic. Until next time.